Insight into the COVID pandemic for us all and its impact on athletics for the medium term. It's my honour to extend a very warm welcome tonight to Professor Kingston Mills, the Academic Director of the Trinity Biomedical Sciences Institute. As many of you are aware, Kingston is a distinguished member of the Athletics Ireland family, having represented us many times on the international stage. Georgina Drum, our president, and I were very fortunate to hear Kingston's presentation 2 weeks ago at the European Athletics Conference, and I have no doubt that tonight we will all gain further insights into the medium-term impact of the pandemic. Tonight, Kingston will speak for approximately 35 minutes and then take questions via the chat, as Dara has said, and Dara will facilitate that. So thank you in advance, Kingston, for volunteering your time tonight, and over to you.
Well, good afternoon, everybody. And first of all, I'd like to extend a great thanks to Hamish and Dara and Athletics Ireland for inviting me. I feel a bit of a fraud speaking in front of the Athletics audience. I don't know how many years since I was an athlete. I'm going to try and share my screen. And I hope you can all see that now. I need to put it on full view if I can do that. Okay, so let me go straight to the, some of you who are as old as I am might remember me from the days when I was running in the 1980s, and there's a photograph there of me running in the National Marathon against my still friend and former colleague in Trinity, Roy Dooney. And of course, I did run in a couple of World Championships, including the one in Rome, and I think it was 87, and the marathon. Anyway, these days I've given up the running track for science, and I'm currently in Trinity. And this institute, which you can see in the image on the top right, is Trinity Biomedical Science Institute that I'm the director of. We have about 350 researchers in this institute, and we're working on other things, including COVID-19 research. And of course, COVID-19 is a new area for us all. We only started on this around April, May, shortly after the pandemic broke. We were lucky enough to get about 7.5 million from government, including 2.5 million from Allied Irish Bank to start the research project on this. I worked in London during my training years, and of course I was a member of Civil Service Harriers here in Dublin, Trinity, and then Shaftesbury Harriers, you know, overlapping with Dave Bedford, the world record holder for the 10,000 at the time. And so it was an interesting time to be in London and be part of athletics there as well as in Ireland. So a little bit of background on COVID-19. I think some of the terminology sort of can be confusing. The virus is called SARS-CoV-2, and it caused a disease which is called COVID-19. People usually call COVID-19 the virus. It isn't. It's the SARS-CoV-2 is the virus. And the disease is a pretty horrible one. In some people it's very mild. In fact, about 50% of people have no symptoms at all. And this poses its own problems because it's difficult enough to diagnose it without a test, and people don't know they're infected, and therefore they can transmit it. And that's been one of the big issues with this disease. About 20% of people end up in hospital, or that's less in the last few months. About 2% have very severe illness and end up in ICUs, and its fatality rate is around 0.5 to 1%. And for a comparison, influenza fatality would be 0.1%. Most of the deaths occur from severe inflammation, and what happens is the lungs get, the immune system of the lungs is rapidly responding to the infection, but it gets out of control, and you get what are called these cytokine storms. You get this systemic response, so other organs like the heart and kidneys and even the brain can be affected in severe cases. The risk factors are older age, over 70, underlying medical conditions. Surprisingly, not asthma. People think asthma is a risk factor. It is in long-term recovery, but in terms of getting the disease, it's not a risk factor. Obesity, type 2 diabetes, and cardiovascular disease are the major risk factors for getting severe COVID-19. And the symptoms are, fever, coughing, not typical, the sort of sneezing, and not the sort of typical head cold type symptoms, which tend to be more sore throats and runny nose. Those are different from what people with COVID-19 get. So the most common one is fever and then coughing. Transmission of the virus is largely spread by droplets. So you can see the image in the top right of a person who sneezes or coughs. They emit these droplets, fine droplets of liquid that comes from their mouth or nose, and this contains the viral particles. So if you're in the vicinity of someone who's coughed or sneezed and they're infected, it's very likely you'll get infected. And that's why wearing masks is very good, and I'm going to come back to masks later. The image on the bottom right of the virus load in yellow shows that there's an incubation period which is up to 5 days. And then there's a period when you're infectious, even before you have symptoms. And this is also important. So the pre-symptomatic phase, a person can be infectious. And as I said already, people that have no symptoms can be infectious and they can transmit the virus. So that's important from terms of maintaining integrity of reducing the infection spread. Physical distancing is important. Mask wearing or face coverings can reduce transmission. Outdoor activity, the transmission is much lower. That's obviously very important for athletics, because I don't think, I'll come to the risks associated with athletics a little later, but indoor activity is much more prone to transmission, simply because the virus stays in the atmosphere for longer, whereas outdoors it just gets simply blown away. And as I said already, can transmit in the pre-symptomatic stage as well as asymptomatic individuals. So where are we worldwide with this right now? This is data from 2 days ago. And the color schemes, the red obviously are the more intense countries. And you can see that Ireland is one of those countries, unfortunately. In fact, practically all of Western Europe, United States, a lot of South America, although, this is based on numbers of cases per 100,000. Even though the numbers of cases in a country like Brazil is vast, the numbers of cases per 100,000 is actually higher in Ireland than most of Europe than it is in Brazil. Argentina and Colombia are pretty bad right now as well as Libya. But what you can see is Southeast Asia and most of Africa, Australia, New Zealand, very much lower cases than we have in Europe and in the United States. So it's been a big surprise that Africa has escaped, although the reporting of cases in a lot of African countries is much lower, so that accounts for some of this, but not all of it. In terms of the trends, what you can see on the upper graph are the cases per day, and the lower graph, the deaths per day. And what you can see is still out of control in Americas. That includes South America and the United States. Asia, that's largely down to not Southeast Asia, where it's doing very well. That's largely down to India, Iran, Iraq, Russia, where it's still raging. Europe, having had a peak around March, April, is now having a second peak in most countries, and I'll come back to Europe in a minute. The death rate is still increasing significantly in the Americas, North America and South America. In Europe, it's not quite as bad as it was on the first wave, and I'll come back to that in a minute. If we look at the comparison of countries in Europe 2 weeks ago compared with now, well, it's the 12th versus the 26th of October, to be precise. And the colors here are based on the numbers of cases per 100,000 for a 2-week period. And the red obviously is the most intense cases, and the lighter colors are the least intense. And what you can see on the left, 2 weeks ago or a little over, parts of Spain, France, Switzerland, Belgium, parts of Northern England, also Northern Ireland were very, very high. But what we can see now today is that a lot more countries, including Ireland, are coloring red. So they've gone up. The numbers of cases per 100,000 is now over 300 in the whole of Ireland. So we really are, as is Spain, France, Belgium in particular, and the Czech Republic, very, very bad. And I'll come back to Poland towards the end, because obviously it's important from the athletics perspective with the indoor championships there next year. So as you can see, Europe not doing very well. If you look at the trends in a few of the countries, and on the left we have cases, on the right we have deaths. And this is on a log scale, so it contracts the differences between the the numbers. But these are a few countries: Germany, Spain, France, Italy, Sweden, United Kingdom. And what you can see, all countries are getting into a second wave, except for Sweden. And Sweden went for a liberal policy of not going for this, what we call herd immunity, which I'll come back to later. They had a more liberal policy on not locking down. And the consequences of that is that the wave maintained. It didn't dip like it did in the other countries. And the numbers of deaths in Sweden were initially very high, although now they're declining. And what you can see in the right figure is that the numbers of deaths, and remember this is on a log scale, so you're talking about 10-fold more deaths at the peak of the infection in March than there are now in most of those countries. So the death rate is much lower than it was in March, even though the case numbers are now higher per 100,000 than they were in March. So why is this? One of the reasons is to do with the age, and I'll come back to that in a minute. But if you look first at the statistics in Ireland, this is the number of cases per day, which reached a peak of around 1,000 in March, and it's now went back up and dropped down to virtually, less than 10 per day, and is back up now at just under 1,000 cases per day. So our second peak is actually worse in terms of cases than our first peak. But the death rate on the bottom graph shows that we peaked at maybe 75 deaths per day, and now it's much, much lower at an average of 2 or 3 per day. I'm not trivializing the deaths. It's terrible that anyone should die from this, but the fact is that this is a different scenario now than it was in March. One of the reasons for this is to do with the age. If we look at the cumulative cases, this is over the whole entire period of the pandemic in Ireland. The cumulative cases per age group on the left, you can see that the dominant age group is actually the 15 to 24, 25 to 34. So the sort of early adulthood years are the dominant ages that got infected. And now if you look at the statistics for the last month, it's even much greater in those cohorts. So the younger population are the dominant population that are now infected. However, when you look at the middle graphs, the hospitalized cases, you'll see that it is a much older population, the over 60s and over 75s, that are the dominant population that end up in hospitals. But what I will draw your attention to is people as young as 5 to 14, 37 cases ended up in hospital in Ireland, 123 15 to 24-year-olds ended up in hospitals. So this is not a disease that can be trivialized amongst an athletic community. And most of you who are athletes would be in the age group probably 15 to 34. And you see 264 people ended up in hospital in Ireland at the age group 25 to 34. So it is a significant issue, although much greater in the older population. Now, if you look at the death rate, it's dramatic in that there was one death in a 0 to 24, but there were 833 in those over 85, and that accounted for 44% of all the deaths. So it really is an age-related fatality associated with this disease. That's not to say that younger people can't have fatalities, they can, but they're just significantly less of them. This is the trends in Ireland again of hospitalization, ICUs, admissions, and ventilator use. And the revealing graph really is the one in yellow. And it's not, the peak of the early March is not on this. The peak was 879 people in hospital. Now we have around, sorry, this is daily cases, 879. The numbers of the daily cases. Yeah, no, this must be that on the daily cases is calling it per hospital. Yes, 879 were in hospital, and now is significantly less than that, but it's still going up significantly compared with, this is over a 14-day period, where it was in March. So the numbers ending up in hospital has crept up now. It's roughly around 30, 35 in ICU then, and 300 in hospitals. So the number of ICU is still not causing a huge issue for the hospitals compared with what it did in March, but it's getting close to the situation in certain hospitals are at capacity. So just coming to the immunology of this, I'm an immunologist, and this is my one slide to attempt to try and explain to you why immunology is important in this disease. What happens when somebody gets infected with the virus? They get sick, and 99% of people will recover. And then those people will be immune, at least in the short term. If there are 2 or 3 or maybe a half a dozen examples amongst 40 million people that have been infected of getting reinfected. But by and large, people who get infected recover, and then they're immune to further infection. Now, that's obviously one way of getting immune, but a much better way of doing it is through vaccination. Here you can get immunized, you don't have to get disease, and you're immune. In fact, the immunity generated by the vaccine will probably be longer lived than the immunity generated by the infection. Now, people have said that we should let the virus just spread through the community and get immunity in as many people as possible, and generate this thing called herd or population immunity. Herd immunity is where a threshold is reached where the virus transmission is stopped in the community because it's difficult for the virus to spread. There are so many people that are protected. And this is a very good way of protecting the vulnerable, the older population in particular, where vaccines mightn't work as well. So, but the level of which you need to get to is around 70%. Maybe some people say it's lower at 60%. So 60 or 70% of the population need to be immune, either through previous infection or through a good vaccine to get herd immunity. Now, estimates of the number of people that are infected and therefore immune range from as high as 44% in a city in Brazil called Manaus, 22 to 34% in New York, 15% in London, and only 3%, although that data is a bit outdated now, it's probably closer to 10% in Dublin. And as you can see, that's very much short of the percentage that you expect to get herd immunity. So we're way off herd immunity right now by natural infection. I don't think we're ever going to reach it. So the only hope for herd immunity is through a good vaccine. This takes me to vaccines and treatments. So you'll probably have heard that when President Trump got COVID-19, he got 3 different therapies. He got antibody therapy, an antiviral drug, and an anti-inflammatory drug. So what the antibody therapy does, these are antibodies that are made artificially in the lab, and they can attach onto the virus and stop the virus from infecting cells. If used early, they can be effective, but if they're used too late, they're not effective. The antiviral drug remdesivir is the only really antiviral drug that has any efficacy at all, and its efficacy is rather limited. In a recent trial, it was shown in severe patients to have no benefit. So it's not great news on the antiviral front. The disease, as I said earlier, is caused by severe inflammation. So in fact, steroids, corticosteroids, dexamethasone, is now the treatment of choice and quite an effective drug for stopping the lethal inflammation. And that's partly why the numbers of deaths now is lower than it was in March, because nearly every patient that develops COVID-19 that's hospitalized will be put on this drug. And it does prevent the severe inflammation. But the best chance we have of preventing the infection and dealing with the pandemic is through a vaccine. Luckily, the world's scientists and pharmaceutical industry are really collectively doing a fantastic job here. There are around 150 vaccines in various stages of testing, of which 12 are in the last phase. There are 3 phases of testing, phase 1, 2, and 3, that test the vaccine in cohorts of volunteers for safety and finally for efficacy. And 12 of these are in the last phases of testing. There have been limited approval given to some in China and in Russia, but in Europe and North America, there's none yet approved. We expect the first data from the efficacy trials, the phase 3 trials, in the end of November. So the rollout of a successful vaccine, as I said, the first trial data will be coming in under a month. And then we'll know whether it works or not. If one of these 12 that are in the front runners work, it could be going for licensure the end of this year, early 2021. Bizarrely or wonderfully, the manufacturing facilities for making these vaccines are already being built, even though we don't know if they work. So the vaccine manufacturers are taking a punt on this, and it's been helped by government money. They're actually manufacturing, they're quite sophisticated, the facilities for making vaccines. So they're already under construction. And Pfizer, the lead company, expects to have 100 million doses ready in the next couple of months, even though they don't know yet if it works. So that's fantastic progress. So who's going to get the vaccine? The first target is going to be the healthcare workers, frontline workers, the elderly and the vulnerable, people with diabetes, heart disease, etc. underlying medical conditions, and then eventually the entire population, including young children and infants. So if we're going to get herd immunity, we have to immunize everybody. And obviously that's going to be a logistic, huge issue, getting a vaccine to everybody on the globe, 7 billion people. Some of the vaccines will need to be given twice, so we're talking about 14 billion doses. It's not going to happen overnight. The other big issue facing us is that there's hesitancy about taking vaccines. In a survey done in Ireland by MRBI for the Irish Pharmaceutical Association in July showed that 73% of people said yes, but 17% no, they wouldn't have it. In a more recent survey done by the same group, relatively small survey of around 1,000 people, showed only 55% said yes, 33% said don't know, and 12% said no. So that's a bit disappointing, and I really think it's very important that we get the message out there of the benefits of vaccination. Anyone who has young daughters, or if you're young yourself and female, or indeed male, you would hopefully have had the human papillomavirus vaccine. This vaccine stops cervical cancers and cancers in men as well. And it really does work, 95% efficacy. It's going to wipe out cervical cancer. That's one of the huge good examples. Other ones like polio has been wiped out, or is close to being wiped out by vaccination. There are only polio left in 2 countries in the world, Afghanistan and Pakistan, and smallpox has been eliminated thanks to vaccination. So the PR job needs to be done here. The other thing that's happening is that a bit of vaccine nationalism is creeping in that countries like the US, the UK, and even indeed Europe are making advanced purchases of vaccines that they even don't know yet whether they'll work or not, to be getting to the queue first to get their hands on the vaccine. So just a few bits and pieces about what you need to be doing to limit the spread of the virus. Limiting contact goes without saying. Social distancing, especially indoors. Mask covering. If you look at the image on the right, there's no point in you wearing a mask yourself if everybody around you is not wearing it, because that's not going to really stop transmission. Everybody has to wear it. And it's particularly effective if the person who has the disease is wearing the mask, because that stops transmission to others. So everybody wearing masks is crucial. Contact tracing, testing, and isolation is a crucial part of any strategy to control this pandemic. Ireland struggled a bit on this, but most countries in Europe have struggled. Southeast Asia have got it right, so have New Zealand. It can be done, and I'm hoping that we're involved in some work on testing ourselves, and we have some more rapid tests, which I'll tell you about in a second. International travel restrictions. I've been shouting in the media about pre and post travel testing as opposed to isolation after travel, because I think it's much more effective. It allows people to go about their business, whether it be sport or business, just straight after travel. If they get in a test 4 or 5 days before travel and on arrival, they're looking at this now, and some countries are already starting to implement it. So testing, a little bit of the detail on this, because you might have heard in the media about testing and just some of the description of what they are. First of all, if you look at the upper curve, you'll see the sort of the virus in blue, the time at which it's replicating in the nose and the lungs. And during this period, you can detect the virus by various viral detection methods. And then later in infection, the body starts making antibodies against the virus. And those antibodies persist long after the virus is cleared. So antibody tests can be used to detect previous infection. And they're very good at telling you if somebody has previously been infected. They don't tell you that you're currently infected, but you've previously been infected. So the other type of testing is testing then for the virus. And you've heard the PCR test. This is a way of amplifying the nucleic acid for the virus. It's very sophisticated, slow, detailed, difficult test that requires sophisticated equipment, but it's very sensitive. Now, what we're doing and what a lot of other groups are doing, when I say we in Trinity are currently testing our students using saliva rather than swabbing, which is a much easier way to give sample, but also using a much more rapid type of PCR called a LAMP test, which can be done in 30 minutes and can be done in a high throughput way. They're currently using this also in Heathrow Airport now for testing some individuals going to certain countries like Hong Kong. So it's going to come along. It's just when we can persuade the authorities here to really grasp it, it may come. There are also these rapid antigen testing kits that are available, but they're not very sensitive, unfortunately. So my favorite one is the middle one, the LAMP test. The impact on sport, which is really what you will probably want to hear and probably know about anyway, but I'll put my twist on it. Obviously, we know the impact it's had, the cancellation of the Olympics, our own European cross-country in Dublin. Cancelled, although I do believe it's more postponement than cancelled. I think it's going to be held next year, hopefully. You know, the Diamond League was held in a very blunt way with no spectators. And you probably know last weekend, the Barbarians rugby match against England was called off the last minute because of some of the players deciding it was a good idea to go out for a few pints the night before the match, and then the thing was called off. I have been advocating the benefits of exercise, and this is on the bottom. You know, it goes without saying that regular moderate exercise, and this is taken from an American College of Cardiology article, regular moderate exercise has an abundance of beneficial effects beyond cardiovascular system, mental health, and boosting the immune system. So running and training for running is just a really positive things in terms of your health, whether it be physical health, but also mental health, to get through this COVID-19 stress, if you'd like. Now, I was interviewed by Athletics Weekly a couple of months ago when things were looking a bit better in terms of COVID-19, I have to admit, and Ian Reardon also interviewed me for the Irish Times, and I was advocating, you know, a return to sport at that time, and that we should be pushing the authorities to allow all competitive sports, including rugby, Gaelic football, and running back with maybe limited spectators. But then this happened in the bottom right, on the right-hand image, and you saw this Gaelic football match where the crowd invaded the pitch and nobody was wearing masks. And that really, you know, was a bad image for sport. And I had been telling, I'd spoken to the Leinster Rugby, and I was, you know, advising them to link up with the GAA and you know, collectively have a voice to persuade government to allow more sport and some spectators on sport. But unfortunately, issues like this in the Gaelic football matches really, you know, put paid to, in the shorter term, spectators at sport. Now, I'm not blaming it entirely on the GAA, but certainly doesn't help. So what does it mean for athletes and athletics? Individual training, there's no risk. Training in ones and twos or fours or sixes, I don't believe there's any major risk outdoor. The thing about outdoor training is the virus will get blown away pretty quickly. So it's not going to be easily spread. What are the risks associated with training are crowded changing rooms and crowded public transport getting to and from the training, not the training itself. In terms of competition, we've seen that mass marathons can occur without spectators, with elite runners only, such as London, and to a lesser extent Dublin, which had an innovative way of dealing with the issue. Track and field, can take place, and we had the Diamond League meeting, some of them without spectators, but clearly mass participation events, such as mass participation marathons, are not going to be a runner at the moment because of the difficulties of social distancing. Clearly, competition poses its own stresses on how you're going to be able to deal with, try to keep people at a distance, because it's not just the runners or the spectators. You have coaches, you have officials, you have press. All of them have to be kept at a distance in order to try and do the thing safely. The other point, of course, is that most international competitions will involve travel by flights to the competition. In my view, this poses a bigger risk than the competitions themselves. And in terms of spectators, the crowds getting to the matches inside the stadium, you can distance them, and perhaps it's possible to have competitions where they're held fairly safely. But it's what happens before and after is the bigger issue. You'll be aware that the European Indoor Athletics Championships are due to be held in Poland in March, and Poland was in a pretty good place a few weeks ago, even a month ago. But right now, the numbers of cases in Poland has really gone through the roof, and it's now one of the hot spots right in the middle of where the European Championships have been held. And Poland have introduced stricter measures now than they had even before in the earlier part of the pandemic. So it's not looking great in Poland at the moment. So what are the measures that could be used, and this is my final slide, to reduce the risks for athletes, officials and organisers? I think testing is key to this. The professional rugby bodies have tested weekly. The Leinster Rugby and the RFU and the other major professional rugby organisation are testing their athletes once a week. I think you should test 5 and 1 day before competition, and that makes sure that you catch every possible case, and do it by these not the rapid script tests, but either by PCR or LAMP testing. Obviously, before and after arrival at international travel, I've said that already. Social distancing where possible, compulsory wearing of masks, except when athletes are competing, obviously, even by all officials and spectators. Avoid public transport if at all possible. Obviously, that's very difficult if you have to fly to another country to do a competition. Changing rooms, limit the access to changing rooms, and also holding areas for prior to events, keep those to a minimum. For spectators, control entry and exit, distancing seating arrangements, compulsory wearing of masks. And dare I say it, it could even be possible to test every spectator before they turn up at a match. And they've, in the UK, they've talked about this. Boris Johnson, in an interview I heard him say, he didn't talk about sport, but he talked about the theatre, saying that, people who went to the theatre could, in theory, be tested in advance of going. And I think this could be applied to sport when we have rapid testing approaches. So there are innovative ways that we could get back to sport, and hopefully by the time the European Indoor Championships and the other competitions happen next year, we will be at that position. Okay, I'll leave it at that. Thank you very much. I'm happy to take questions.
That was brilliant, Kingston. Thanks a million. Some stark numbers, I suppose, to start with, but I suppose we're all bombarded with so much COVID-related information over the last number of months now. It was great to get the definitive line. So we've a number of questions that were submitted there kind of throughout the presentation and advance as well. Now, I know you've touched on a lot of them already, but we might just pop through them, just people kind of joined at different stages there. So just in terms of the first one, when do you think the general public might have access to the vaccine or a vaccine?
I think it depends on, first of all, that we have one that works. How many vaccines do we have that work? And then we will know greater how much there is to go around. But if you look at what Europe has done, Europe has already advanced to order several 100 million doses of vaccines. So, and the US have done the same. So, the healthcare workers and the high risks will get first, but we're talking about, I would say, towards the end of next year, before the general population, there will be mass vaccination. That's assuming that some of the front runners are the ones that get the front running vaccines are the one that come up trumps and that they're effective.
Perfect. And we've one here. Is there a slipstream effect we need to be concerned about for virus transmission?
I presume they mean when they're actually running. I mean, to be honest, I've heard you say that there was something about joggers transmitting the virus, around the time, I think it was April or May in the media, and I poo-pooed it and said I didn't really think this is a big risk. Really someone has to sneeze in your face before you're going to transmit outdoors. I don't think that's a huge risk in my view.
Perfect. And we did another question there, pretty much along the same lines you've just answered in terms of how safe are long runs outdoors. So in terms of the next one, how long do you think we could be in the restricted lockdown setting? And do you think this will be our last full lockdown in inverted commas?
I hope so. I'm not a big fan of lockdowns. I think they're a very crude way of dealing with this issue. I'd much prefer to see everybody buying into less restrictive measures and having very good contact tracing, testing, and isolation procedures. The problem with the pandemic is that a lot of people have no symptoms, and they think when they have no symptoms they're not going to transmit the virus, but they can. That's been the big issue with this. People not going for tests or not taking it seriously to isolate when they don't think there are any risks simply because they don't have symptoms. So to answer your question, it very much depends on how well the current 6-week lockdown works out, and then how effectively we put in place the measures for better quality testing, but also limiting importation again, because remember, if we get it down to very low levels in Ireland and the UK or France or wherever else has high numbers, and we allow air traffic to come in from those countries, we're just going to re-import it again like we did from Italy at the very beginning. So we absolutely have to put in place a system of testing pre and post arrival. It's the only way that we're going to deal with this.
And just another question there, is there an increased rate of false positives with the LAMP test?
No. If anything, the PCR is very sensitive. The LAMP is slightly less sensitive, so it's less likely to pick up false positives. It's more likely to pick up false negatives. But I would say that based on what I've seen, one would be at maybe 90% the LAMP and the PCR 95% in terms of picking up cases. So, and it does very much depend on when you take the sample and the type of sample. I mean, I'm a big believer in using saliva for the sample because it's easier for the person to give it. And some of the reasons why people don't go for tests is they don't like the swab put up their nose. I don't think the false positives with the LAMP is an issue.
Perfect. And we might just take one or two more now. What is your view on the rationale for level 5 restrictions with regards to allowing adults to train individually, even with outdoor non-contact sport?
Yeah, I mean, I think that I'm a cyclist these days because of the injuries put paid to my running. Well, I'm too old anyway, but so I have to now cycle around 5 kilometers from my home, which is absurd. And I know that if I cycle up the Dublin or Wicklow Mountains, I'm not at risk to myself or anyone else. And the same at running. I mean, it's one of the anomalies of the whole thing, that going out for a long run could in any way put yourself or anyone else at danger, especially if you're on your own, or even one other. I don't think there's any risk to it, quite frankly. But I mean, of course, the government policy says otherwise. And we have to stick with the government policies on this. But there is not a lot of common sense. I know the golfers are up in arms as well, that they can't play golf. And again, that's also anomalous, because I think the golfers could safely do it without going to their clubhouses and play in 2s or even 4s. So there is a bit of lack of common sense along some of the measures. I think the problem is that if you stretch the limits of what's allowable, then everybody sort of breaks the rules. And it's easier just to be draconian, I suppose. That's the way I think that NIFET and the government are thinking on this. So I do have some sympathy for that view, but at the same time, I have a huge sympathy for the runners and all the other sports people whose enjoyment of the training and competition has been affected by all of this.
And we might just take one more question. I'm conscious we're running over the 40 minutes there now. Just in terms of your view on children training in pods of 15, do you think this is okay? Obviously, I think a lot of them are training outside.
I think that the transmission of the virus amongst children is very much lower than it is in adults. And the main reason for that is because the virus just doesn't multiply much in a child compared to an adult. So they don't tend, they can transmit it, but the transmission is much, much, much less than it is. And you see this with the schools. I mean, the fact that we have seen a relatively small number of cases in the schools after reopening, vastly less than are in family homes or associated with activities that involves adults. So I don't think that that there's huge risks associated with being in a schoolroom, and there's much less risks associated with being in an outdoor park than there is in a schoolroom. So I think I think the risks are much lesser for kids, and they're lesser outdoor than indoor.
Brilliant. So look, Kings, that's absolutely fantastic. Thanks on behalf of everyone, I suppose, that has tuned in there. Thanks a million. It was absolutely brilliant. In terms of anyone that might have missed section of it there, that we will be publishing this on our YouTube channel the next day or so, and the slides will be included there as well. So Kingston, on behalf of us all, thanks very much, and enjoy your evening.
Thank you, guys. Great to see you all. I don't know who's there, but
thanks, guys.